Cancer Conversations, a Harold Leever Regional Cancer Center podcast discussing all things cancer and giving you information to improve yours or a loved one's cancer journey. Hello and welcome to Leever Cancer Conversations from the Harold Leever Regional Cancer Center. Today we're happy to welcome Dr. John Zhang, renowned colorectal surgeon, to talk about colorectal cancer. We'll be discussing prevention, symptoms, screening, and treatment. Hello, Dr. Zhang, welcome.
Hello, this is Dr. Zhang. I'm happy to be here.
To get started, let's have you tell us about yourself.
I'm a colorectal surgeon working in Waterbury Hospital. I joined the hospital in 2010 after I finished my colorectal fellowship from Cleveland Clinic, Cleveland, Ohio. And since then, I'm working on colorectal cancer and other colorectal diseases in Waterbury Hospital.
What can you tell us about colorectal cancer?
Colorectal cancer is the second most common cancer. We know lung cancer is still number one. For females, breast cancer number two. For males, the prostate cancer number two. If you put both males and the female together, colorectal cancer becomes second most common cancer. So in general, in the United States, about 150,000 new cases colorectal cancer, also called large bowel cancers, about 100,000 new cases of colon cancer, and approximately 50,000 deaths annually. So this is pretty common cancer. So that's why we're going to talk about this. Another reason is March is National Colorectal Cancer Awareness Month. So that's very important to talk about colorectal cancer.
You've previously said that patients come to you who have colon cancer and say they have no family or personal history, and they want to know why they have colorectal cancer. What do you tell them?
I talk to my patient almost every day regarding this kind of questions. So let me give you some idea why we have colorectal cancer. In general, there are several groups. Most common group we call sporadic cancer. Sporadic cancer means just happen randomly. That's about 60 to 80% colorectal cancer. 10 to 30% with family history. About 5% we call another term called HMPCC, also called Lynch syndrome. Another familial colon cancer syndrome. About 1% we call FAP, which means familial adenomatous polyposis, and less than 0.1% very rare syndrome. Most people have no family history, just happening like a sporadic. The question is why? Like to answer your question is why happening? It's really not that simple, not like one risk factor. So I summarize approximately 10 risk factors affecting your colon cancer. So we know that number one is age. Older age, higher risk for colon and rectal cancer. Genetics, some gene mutation associated with colorectal cancer. Personal family history, number three. Number four is called IBD. That means it's called inflammatory bowel disease, which include Crohn's disease and ulcerative colitis. Number five, diabetes. Diabetes increases cancer risk. Obesity is another risk factor. Alcohol has risk factor in terms of colorectal cancer risk. Smoking and lack of exercise and the American diet, which is low fiber diet, is high risk.
What can people do to help prevent colorectal cancer?
To prevent colon cancer, we have to target the risk factors. In general, lifestyle change, more exercise, stop smoking, stop drinking. So far, the only cancer can be prevented is colon and rectal cancer. Not breast cancer, not lung cancer, you can prevent them. The one cancer can prevent is colon and rectal cancer by doing screening colonoscopy. In the past, everyone age 50 above need a colonoscopy. The screening colonoscopy means when we see a polyp, you remove them, potentially can prevent. Nowadays, the National Older Organization lower the screening colonoscopy age from 50 to 45 years of age.
Can you talk about the language of cancer and cancer staging?
When we talk about cancer, any cancer, the important thing is staging. Colon and rectal cancer is a curable disease. Survival sometimes associated with staging. Staging we talk about from stage 1, 2, 3, and 4. Stage 1, early staging. In general, after surgery, is cured. Stage 2, 3, and 4, sometimes surgery enough, sometimes you will need some, we call it adjuvant chemotherapy for those disease, but still curable.
After staging has been completed, what are the next steps for treatment?
Every single patient is different. So we individualize the treatment. That's why treating colorectal cancer is not one doctor job. Over the last 10 years, we gradually build a very good team in terms of colon and rectal cancer management. So the team is, for example, for rectal cancer, we have a group of doctors from 5 specialties: medical oncology, radiation oncology, pathology, and radiology. But the key has to be really professional trained colorectal surgeon or a general surgeon trained for rectal cancer treatment. We meet twice a month at the Leever Regional Cancer Center for a multidisciplinary conference to talk about every single patient, from pathology and staging with imaging studies, and discuss the treatment plan. The question is, who need surgery first, chemo first, chemoradiation first? So we have to discuss as a group and have a very detailed treatment plan.
Now, just to go back, how would somebody know that they might have colorectal cancer? Can you talk about the symptoms that people should look out for?
Most time you don't know. We have seen so many patients, having the first screening colonoscopy found have colon cancer, rectal cancer. But most people, they present with referral from our GI colleague. However, sometimes we do see some symptoms. For example, anemia. For healthy adult, anemia is not normal. So the next step is a colonoscopy. Make sure you don't have any chronic bleeding in your GI system. Abdominal pain, when the cancer getting bigger, it may cause pain, or we call it blockage, also called obstruction. Blockage, obstruction give you pain, nausea, vomiting, bloating. Late stage sometimes become fatigue or weight loss, abnormal weight loss, with worry, or bowel habit change. Before in the past, you're moving your bowel once a day, and now I see a lot of patients having bowel habit change. That means the stool, the caliber getting smaller, pencil thin, small stool, called fragmentation, small pieces, and you see some bloody bowel movement. Those all concerning. So the next step will be a colonoscopy. This is called a diagnostic colonoscopy. It's a little bit different from screening. So diagnostic colonoscopy, like figure out where spleen come from, why you're having bowel habit change.
What do you think about the other types of screening that are available? I know that some patients have come to you with a Cologuard test.
That's a very good question. From a colorectal surgery standpoint, we prefer screening colonoscopy. That's gold standard in terms of screening colon and rectal cancer. However, we know that some patients, like a high-risk patient, where they can't handle the colonoscopy, they can't handle those preparation, or they can't handle the procedure. So now the newer one we see on the TV all the time called Cologuard. Cologuard means do DNA study. So basically try to identify any abnormal DNA in your stool. The problem is if that Cologuard stool DNA test positive, we see a lot. They refer to me for positive Cologuard almost every week. That means The next step, you will need colonoscopy. Figure out why you have abnormal stool DNA.
Right.
Hmm.
By the time the person has symptoms, you're suggesting that they've already had the cancer in their system. Tell me a little more about that.
Almost every single colon cancer started from a small polyp. Polyp gradually become colon cancer. This whole process takes average about 5 to 10 years. So in the beginning, when you have small polyp, you have no symptom at all. The small polyps slowly become bigger. When they become bigger, sometimes cause chronic bleeding. Slowly, gradually, you become anemia. When the tumor or polyp getting bigger and bigger, become cancer, can cause bleeding, obstruction, or perforation. Sometimes we have to do emergency surgery. Like last week, we had a young lady in the emergency room with a colon obstruction. So we had to do emergency surgery to save a life,
Wow, that's incredible. Let's talk a little bit more about surgery. What are the different types of surgery that may be needed?
The best treatment for any cancer is prevention. So again, one more time, the colonoscopy is important. Do your colonoscopy to prevent colon cancer or rectal cancer, number one. Number two is, like you talk about, when the patient show up in my office or sometime early in the emergency room, they already have colon cancer. So what should we do? Most important thing for any cancer is staging. Staging means you, in general, some imaging study such as CT scan, chest, abdomen, pelvis, and some tumor markers, draw some blood. After complete all the staging, some patient may need operation first. We do surgery. So in the past, everyone do open surgery, the big surgery from big opening up and down. So a lot of pain and sometimes complication, wound infection, bleeding. So now gradually we move to minimal invasive procedure. We start with laparoscopic surgery for colon cancer, rectal cancer, and slowly now we move to robotic surgery, robotic single port surgery, or really minimal invasive surgery. Now we do smaller incision, you go home sooner, less pain, less bleeding, good outcome. Another thing is happening now. It's very amazing. So we just had a meeting this morning with my surgical resident. We talk about this. We talk about a lot with a group of doctors. For example, for rectal cancer, nowadays more and more move towards total neoadjuvant therapy called TNT, total neoadjuvant therapy. That means usually in the front, we give chemotherapy or chemoradiation. After chemo and chemoradiation, we restage patient. 2023, approximately 30% patients after TNT, the cancer disappear. What that means you are really good responder. You respond to treatment. No more residual disease, no more cancer. You don't need any operation. We have a lot of patient follow-up. We need a close follow-up with a group doctor. We talk about that 5 group. The group doctor, we do that follow-up with you for the next 5 years. Close monitor. We have so many patients now having those called clinical complete response, which is very good, really depend on tumor biology. So some patient with a partial response, we can provide the robotic surgery to complete the surgical resection and look at specimen again. It's still curable and less invasive now.
Well, that's very hopeful with very positive outcomes. So that's new and different, and I think that's fantastic that we're moving in that direction.
Yep.
Do you have any other things that you would like to add about colorectal cancer? Prevention, symptoms, screening, or treatment?
To summarize this, lifestyle change, number one. Number two, need a screening colonoscopy. Everyone needs colonoscopy, start from age 45. Number three, if we see a polyp or precancer polyp, we can remove it. By removing the polyp, potentially prevent cancer. You don't need any operation, don't need any surgery. So if we see the early colorectal cancer, we can do a lot of new technology without major resection, without major surgery, it still can be cured. Even though the late colorectal cancer, don't give up. We have a group, we have the technology now, we can treat every single patient differently, really based on your staging, your tumor biology, it's still treatable. It's not a one doctor job. We have a very good group with me for more than 10 years. I'm very happy to be here and to provide the best service to our community.
That's a good way to end this discussion. Thank you for being with us today and sharing your expertise. We look forward to talking with you again in the future.
Thank you so much.
Be sure to check out our website, levercancercenter.org, for more great content and new podcasts. Content produced by Leever Cancer Conversations is for the community and is for education purposes only. We do not diagnose, treat, or offer patient advice. Thanks so much for listening.